Let's hear a word from this episode's advertiser. Earn a reputation of excellence in cancer care. Visit facs.org/cancer to learn how to achieve accreditation from the American College of Surgeons cancer programs and visit the Cancer Programs virtual exhibit booth during the 46th Annual ONS Congress to learn more. You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, oncology clinical specialist at ONS, and today we are joined by ONS member Martha Lassiter, clinical nurse specialist of adult bone marrow transplant and hematologic malignancies at Duke University Medical Center in Durham, North Carolina, and member of the North Carolina Triangle ONS chapter, to discuss home-based transplants, which we will call HBT for the rest of this episode. The advertising messages in this episode are supported by the American College of Surgeons cancer programs. Thanks for joining me today, Martha.
Thanks for having me, Steph.
So, Duke's BMT program is well established, but to start us off, where did the foundation for HBT program come from?
So probably about 12 or 15 years ago, Dr. Ali Ringden, who is the medical director at the Karolinska Institute in Stockholm, Sweden, visited Duke. One of our physicians was a colleague of his, and he gave a talk about their home-based transplant program that had been in operation for probably 15 years at that point, maybe even more. And so our medical director was intrigued by the outcomes that Dr. Ringden shared with us about infection risks being decreased when patients were cared for primarily in their homes, better quality of life, and the like. And so we researched and decided that we would try to start the same program here at Duke on an IRB-approved protocol.
It's such an interesting concept to do transplants at home. And from my clinical background, being in transplant and what it was, how many years ago, 20 years ago or more, and the fact that we wouldn't even think of letting anybody go home, to now actually having this type of a program is just incredible.
Yeah, it really is something. I've been at this for better than 30 years. And, many of the supportive care that we have now makes this possible. We do the preparative regimen or the conditioning regimen and the actual transplant in the clinical setting. So that's either in the hospital or in our outpatient clinic, which our program's been established since 1992. So we had a really strong outpatient clinic to start with, but the remainder of the care is provided as much as possible in the patient's home.
That's great. So can you kind of take us through the whole process from start to finish for a patient that would be enrolled in this program to have the HBT?
Yeah, absolutely. So a patient is, again, it's an IRB approved protocol. So we have certain criteria for eligibility, and our coordinator will look through the criteria to see if the patient is eligible. One of the biggest things is so we're in Durham, North Carolina, which is in the center of the state, but we live in an area called the Triangle, which is Raleigh, North Carolina, Durham, and Chapel Hill, North Carolina. And so the patient has to really live in that triangle area. Their permanent residence has to be in that area because our goal is to keep them in their normal environment. So we go out and do a home assessment to make sure that the patient is in a safe area, that they have hot running water, that there are no safety issues, that the area is well lighted, and that it's safe for our staff to care for the patient in the home as well. And so once they're assessed, they sign the protocol, or they sign the consent form, and then we provide their preparative regimen and their transplant in whatever traditional setting they normally would be treated in. And then the rest of the care we provide in the home. And how we do that is we have an advanced practice provider who would normally see the patient in the clinic or on the inpatient unit go into the home in the morning and draw labs and bring them back to the clinic and run them. While that providers in the home, they're going to go ahead and do their assessment and see, how the patient did overnight. If there are any issues, make sure that the caregiver doesn't have any questions and the patient doesn't have any questions. They come back to the clinic and huddle with the transplant team, so the attending with the care nurse who's probably going to have to go out and provide care later in the day, and come up with a plan for the day. And so later in the day, then the care nurse will go out and provide whatever the patient needs, whether it's transfusions, antibiotic therapy, electrolyte replacement, fluid replacement, education, and whatever else is needed. During the day, then, the attending physician will do a Zoom call or a FaceTime call with the patient as well, just to make sure that they don't have any questions. And that's a pretty typical day. So there's an advanced practice provider visit, and then the care nurse provider visit, in addition to video calls.
That's a lot of pieces to get together.
It is.
That's for sure. So, a couple of things that I'm thinking about. As you guys were setting this up, let's talk about what was the infrastructure that was necessary to kind of set this up and support HPTs.
So we were fortunate, again, to have a long-standing outpatient successful transplant program back to 1992. And so we had a lot of infrastructure to manage outpatient transplants, patients staying in local housing and coming to clinic for their care, with our inpatient unit as our backup. And that has been our standard since, again, 1992. So we had that infrastructure in place. Our outpatient day hospital clinic, where we treat a lot of our patients, is 7 days a week, 365 days a year. And then again, our inpatient unit acts as our backup. So that we had that infrastructure in place. I think that was a huge benefit for us in having that strength. But it definitely required a lot of coordination with, how do you take care of a patient in the home? We are not home health nurses. We're transplant nurses. And so we partnered with our home health agency at Duke and did a lot of the same training that they did on how to properly care for a patient, following infection control practices, how to safely, get in and out of a home, and those kinds of things. So we partnered with home health. We had to partner with transfusion services because giving transfusions in the home was a new practice for our program. And so we partnered with them to get that approval so that we could do that safely. We used a lot of technology to make sure that our nurse, while they're in the home, has access to us. So we use a lot of iPads, making sure that the patient also has Wi-Fi. And that's probably been one of our biggest challenges, is the technology support and making sure that we're practicing safely in regards to HIPAA and being over secure networks.
Yeah, I can understand where you were saying, just about, we're transplant nurses, we're not home care nurses. And that is such a different, we're nurses, but it's still a different thought process that you're doing when you're caring for a patient in the home versus in, a more controlled environment, where you have everything kind of at your fingertips. But you mentioned right at the end there, one of the challenges that you guys have faced with technology. So were there any other challenges in the implementation of this program that you guys ran up against, and how did you deal with those?
Yeah, there've been a lot of them along the way. We've had to actually stop and start a couple of times because, number one, of staffing. So if you think about your nursing staffing patterns, this is basically a one-to-one nursing assignment for that nurse, whereas our traditional clinic nurse taking care of our treatment room patients is going to have 4 or 5 patients. So people resources were a challenge all the time. We didn't always have buy-in from our attending physicians. Not everybody wanted to offer this to their patients. So we've had to do a lot of education with our attending physicians. The staff, we've done some surveys over time, and one of the benefits that they say of doing this kind of nursing care is the autonomy. And one of the deficits of doing this kind of nursing care is the autonomy. So it's a little bit of a double-edged sword, like you mentioned, because you are there and you're able to provide care in a very intimate way with a patient in their home. But again, if something comes up, yeah, we're only a phone call away, but it's not like having not even the equipment, but the support of the APPs and the attendings right in the room with you. The nurses did a great job of designing what we needed to take into the home. Karolinska was great at sharing all of their resources and what they felt like, we needed to keep in the home and carry as an emergency pack and things like that. So we had a great resource there. And again, our home care nurses really helped our nurses become more comfortable with practicing in the home.
It's just such an interesting idea and program to do. One of the things that I've been thinking about, since you started talking about this, when you were talking about the APP going in the morning and doing the blood work and then a care nurse going out during the day, is that APP, do they do like all of the home HBTs, patients for the day and go see everyone and then kind of come back to home base to the hospital or to the outpatient clinic to go over and do the plan of care? And same for the nurse that goes out for the care nurse for the day. Do they see multiple patients, or how does that process work for you guys?
Yeah, so on the clinical trial, we usually have just a couple of patients on at one time because they may be, one patient may be in Raleigh, North Carolina, and one patient may be in Chapel Hill, North Carolina. And to physically see them both, we might need to send two different people out in two different directions just because it's a huge time commitment. One of the things that we did, we were cruising along with our study, and then, like many people, back in the spring of last year, COVID hit. And so we actually pivoted to try to do this care for as many patients as possible. So we opened up another trial very quickly to treat people who were just staying locally. They didn't even have to be in their own home, because the purpose of the primary endpoint of the first trial is looking at the microbiome and seeing how your microbiome affects your infection rate, graft versus host disease. So if you're in your own home, those are your own bacteria, right? And so you shouldn't be as open to the risk for infection. So when we pivoted during COVID, it had a little bit different premise. That premise during COVID was to keep people out of the clinic. Because as an example, when a patient comes into our day treatment clinic, they are touching base with the screener at the front of the building who's going to ask them all the COVID questions. They're going to phlebotomy. They're going to the front desk. They're going to see their care nurse. They're going to see the APP. They're going to see a physician. So right there is about 5 to 6 touchdown spaces that a patient has a potential to be at risk for COVID. So we decided to, again, pivot and treat as many of our outpatients as we possibly could in the home. So you can imagine that was a pretty big strain on our system. But one of the things we were able to do was to partner again with one of our corporate housing folks. And we tried to put as many patients as we could in 2 apartment complexes near each other so that that care nurse could optimize her time by setting up kind of a base camp and then going into those apartments to see patients. We've stopped doing that now that COVID is much less here in North Carolina, because we were treating probably 6 to 7 patients, as many as 8 patients a day. So it was a lot of juggling and a lot of coordination. So we were able to do that because of our experience with just doing the 1 to 2. So now we're back to doing just 1 to 2. So the short answer to your question is if we have patients who are far away, we have to kind of divide and conquer. But if we can have patients who are in just, live nearby the hospital, if we have someone who's in Durham, that's much easier than to do 1 or 2 with just one care provider and one staff nurse. It's a long answer to a question. Sorry.
No. That's okay. That was really a great answer. And I mean, just wow, how you guys did that and made that pivot for the patients and, to get them to as fewer touch points as possible to keep them from having a higher risk of, getting COVID. That's just wonderful and amazing. So then thinking about it that way and just, your other patients that you have had on protocol from the start of this, what are some of the benefits to the patients for doing it this way?
Patients really love not having to come to the clinic every day. They enjoy the time that the nurse spends with them in the home. Again, it's a much more intimate environment. And we've had one patient on trial early on who we ended up having to bring into clinic every day because she felt very isolated. her caregiver was not her spouse. Her spouse had to work. So they had a lot of different family members coming in to be her caregiver, which is great, but just people she didn't have really, really strong relationships with. So she felt very isolated and got a lot of support from being around other patients, from being around the staff. So we actually pulled her off study and had her start coming into the clinic every day because she felt so isolated. The other thing I think that has happened with our caregivers through COVID is even though we felt like this was better for the patients, our caregivers are very isolated because if they're just in the apartment with the patient, they're not coming to the clinic every day. They're not allowed to come into the clinic anyway, as I'm sure most medical centers and clinics are limiting visitors. But our caregivers get a lot of support, again, from the staff and from other caregivers that they have met here in clinics. So that's one of the things I've noticed as I'm doing a lot of our discharge teaching is that our caregivers really have struggled with the isolation as much or more than the patients during the pandemic. And so I think just in thinking about that, now that we're back and rolling on the trial, we might need to think about some better support for our caregivers as well as our patients from a psychosocial standpoint.
That's a really good point. I think as we try to find ways to make the, treatments for cancer, whether it's transplant or other treatments for cancer, easier on patients or just in a way, like you said, they don't have to come into the clinic every day and all of those things. As we try to do that and we think, oh, the patient, this is going to be great for the patients. I think it's so important that we take into consideration the caregivers because we are putting on them the role and the burden that we as nurses and clinical staff take on every day. But that was a choice that we made. And this is, not that they would never do any, they wouldn't do it for their family member or their loved one, but it's not something that they chose to do. So it really is something that I think is really important for us to consider that, we've got to take in the caregiver's well-being into account as well. It's that whole pod that we're taking care of, not just that one. And especially when we are putting more responsibility or asking them to take on more responsibility.
Exactly. And I think one of the things our social workers have done really well is they've moved our support group to a Zoom format. And they're actually getting more caregivers involved than when we would have an in-person support group. So I think it's just more convenient for them to squeeze that in. But that's one thing I think, we're all going to, I'm sure anybody who's listening to this, who's worked through this past year, we're all going to have to think about how we can capture this technology that we've been able to use and utilize it in the best way, even beyond the pandemic.
Yeah, I agree with that. And, just trying to figure out, it's not new normal. It's just new. What is this that we're doing different now? And making sure that we don't just leave it behind, especially, we can all get together now. But as you said, your social worker is seeing more caregivers participating, and sometimes it's that anxiety of getting together with a group and the anonymity of sometimes being on Zoom or not having your camera on Zoom, allows people to come in. And even if they don't say anything, but just to listen and to take in what others are going through and how that works and, the benefit that it is for them.
Oh, absolutely. I think we're going to need to partner, or pair the two, the technology and the live together and offer a lot more options for patients and for caregivers, because I think that's how we're going to reach and better support people.
And now let's hear a word from this episode's advertiser. Earn a reputation of excellence in cancer care. When you achieve accreditation, you make a commitment to patients that your number one priority is providing them with the highest quality cancer care. The American College of Surgeons Cancer Program's mission is to improve the care of the patient with cancer. We are proud to lead the industry as the primary authority in cancer staging, standards and quality, impacting the care of 70% of patients with cancer in more than 1,500 facilities across the country. Learn how your program can become accredited by visiting facs.org/cancer and visit the Cancer Program's virtual exhibit booth during the 46th Annual ONS Congress to learn more. You mentioned about the staff, just the intimate care that they can give when they're in the home, that relationship that they build. And for me, I think back on, my time in transplant and with very fond memories, and especially of those patients and families that you built relationships with because you were with them so long. It just seemed like forever. And they were there every day, day in and day out. And, the caregivers and the family members were, and the relationships that you built. But this is such a different way because you're right. You're going into their home. That's kind of their safe place, their place away from the hospital where they can feel kind of want to go back to a normalcy feeling. But now you're bringing the nurse into the home, but it's just a really neat kind of relationship that they can build almost on the patient's turf, wherever they are. So what are some of the benefits? You mentioned a few from the staff, but what have you guys seen about that from the staff benefit?
Yeah, I think the biggest thing is just the increase in that relationship. And, we see patients, like you mentioned, that are most vulnerable in our clinic sites and in our hospitals, but to actually go into the home is really a different level of intimacy with the patient and the caregiver. And, some of our nurses, honestly, it wasn't something that they really thought about. If I wanted to be a home care nurse, I'd be a home care nurse. But once we started it, and the biggest thing I think is that if they feel supported, that gives them a lot more satisfaction in their role in the home. So as they bring things to us that, hey, we need this or we need that, we need to listen very carefully because they're the ones who are there that are providing that care. I did a talk at TCT back in 2020 before the pandemic about our home care program. And when I was doing my research, I found an article about home care nurses and hardiness and job satisfaction and stress. And it was a descriptive study, but it said the relationship between hardiness, job satisfaction, and stress among home health nurses, their high levels of hardiness tend to have lower stress and high levels of job satisfaction. So as we can support our nurses to be hardy nurses with anything that they need and the resources that they need to provide that care, I think it's going to help with their job satisfaction. Now, I'm not going to sugarcoat it. During COVID, when we were treating 6, 7, and 8 patients, that was hard. And that was one of the reasons that we pivoted to try to get patients housed in places near each other so that the nurse wasn't on the road a lot and wasn't putting wear and tear on her car. So those are some of the things that I think the biggest thing is to listen to the staff and to really take to heart and to really try to come up with creative solutions to technology and to how to support them in providing this care.
Yeah, that's a really good point. Like you said, since they haven't been home care nurses, it's really important to listen to what things they figure out that they need and would be helpful. So what additional training, you mentioned, working with your home care agency, but what additional training and education did your transplant nurses need to be part of the program?
I think the home care and the infection control practices of taking care of someone in the home were the biggest things. We talked about when we started the program, should we use home health nurses to provide the care? And so do you have a home health nurse provide transplant care, or do you have a transplant nurse provide home health care? And we debated back and forth, and we really felt like our nurses should be the ones to provide the care. So the biggest thing, I think, was just the transition to keeping different equipment in the home safely. Where can we store it where it's not going to be a risk to anybody who lives in the home? an IV pole, our portable pumps. There were a lot of things that we'd already been doing because we had such a strong outpatient program. So those pieces weren't that much different, but it really was, I think, the infection control practices and the safety issues of being in someone's home and away from the clinical site.
Gotcha. So speaking of safety issues, were there safety concerns that you guys had, or what were the safety issues that you recognized in this different kind of setting?
So one of the things I learned, I'm sort of the backup for either going out into the home to provide care or to do home assessments. So everybody would get a home assessment. And, we really don't know as transplant nurses what kind of environment our patients come from before they come to transplant. So that was pretty eye-opening about how people live and very differently. So there were a couple of cases. Well, there was one case in particular where it was not a really safe area for our nurses to travel in and out of, we didn't feel like, so we didn't allow that patient to go on study. The other kind of safety concerns are rugs that, you don't have a lot of throw rugs around that you can trip, that you've got a shower chair, that if you have pets, that they can be placed away from the care area when the nurse is there. We allowed people to keep their pets if they were staying in their home. We don't allow people to bring pets to Durham if they're not staying in their home, but on the home care, we did allow that as long as the pets could be kept away. So those were kind of the biggest safety concerns. And that happened maybe twice that we had issues with some safety issues that we felt like we didn't want, to put our nurses at risk or our staff at risk.
Those are important things. Talking about the pets, and this is kind of a funny or silly memory for me, but growing up, when you're a teenager, you get asked to go and babysit, for someone, and it might be a new family. And I am extremely allergic to cats. And if I didn't remember to ask them if they had a cat, by the time the parents got back that night, I was a mess because of my allergies. And so that would not have been something that would have been forefront of mind in setting something like this up. But you mentioning that would be something really concerning for, your staff. And okay, now we have to manage that there might be a staff allergy issue or something like that. But
yeah, or sometimes people just don't like them. They don't want to be around cats or dogs. So we had to be thoughtful about that and take that into account. And one of the other people that we didn't put on study had 2 dogs. And the minute that Krista Rowe Nichols, who's my counterpart, who is a coordinator for this program, she and I don't remember why, but we went to do the home assessment together, and those dogs immediately jumped on both of us. We were like, okay, no, this is not going to work. So there was a few of those little things, but for the most part, we were able to work around most of those challenges.
Right. So in all of your doing this, and not only Duke setting this up, but in what you've watched from the group in Stockholm, what are some best practices that you've learned throughout this process?
So I invite anybody to look up the Karolinskas experience. They're very well published. Dr. Britt Marie Svan, who was their nurse leader, who I had the opportunity, Dr. Chow and I actually traveled to watch their program for a short bit of time back when we started. She has done a great job in publishing a lot of their data. Many of it is published in the Biology of Blood and Marrow Transplant back in 2000 and 2005. And then Dr. Ringdon in 2018 updated his outcomes over 2 decades. And there was a lot encouraging long-term outcomes, one of them being an incidence of acute graft versus host disease, grade 2 to 4, of 17% with their home care patients and 44% of their standard care patients. And a lot of this we think has to do with the gut microbiome. So we do a lot of studies on stool. We get a lot of stool samples from patients and from caregivers. So I invite anybody to look at those outcomes, or those papers to look at their outcomes, because they have much more experience than we have. So we're hoping to see similar outcomes and similar experiences. We're also looking at some quality of life issues. So do you eat better? Do you sleep better? when you can go to your own refrigerator and pick out a snack that you want. You're in your own bed with your own pillow and your own sheets. They may sound like very simple things, but those are some of the other quality of life issues that we're looking at. And again, we were sort of on a hiatus through COVID because we were caring for our patients in such a different way, but we are back enrolling. And our phase now is actually a randomized trial. So we're actually randomizing people to do a head-to-head. Either they're going to get randomized to home-based care or come to our clinic in the traditional way. So that will give us a more powerful data with it being a prospective randomized trial.
How many patients have you had to date go through the program?
So when I looked back again, when we presented back in 2020 at the TCT meeting, we had about 28 patients. And again, we didn't differentiate from any kind of transplant. So autos, allos, ablative allos, umbilical cord blood transplant patients, it didn't really matter. So we had about 28 patients at that point. And again, then we shifted. So we're hoping to build on that data. It's been slow going. And again, because I think of the resources that it takes, and just because it is so different for us, it's not really been challenging. It's just been a little slower to accrue than we'd like.
So what advice would you have for another institution if they wanted to think about starting a program?
Get your infrastructure in place before you start, because you have to make sure that these patients can be cared for safely in the home. Again, partnering with your infection control staff, with the transfusion services, with your pharmacy, making sure that you can provide as much care as possible in the home, because that's the goal of this, right? So if you can only do part of this in the home, but you have to bring them to clinic every time they need a blood transfusion or a platelet transfusion, that's sort of defeating the purpose. So making sure that you have a good, strong infrastructure and partners who can help you do this safely. Lots of education for your staff to get buy-in. I think those are two key pieces to making this successful.
Great. I could talk to you about this for a really long time, but we're getting to the end, and there's just a couple of questions that I want to finish us up with. First of all, what are some common misconceptions about HBT?
So number one, that we do everything in the home. So I think people have visions of taking your stem cells into the home and infusing them in the home. Now, I'm not going to say that's not going to happen, because again, I've been doing this for 36 years. And if somebody would have told me we'd be doing this kind of care 36 years ago, I would have told them they were crazy. So who knows? Maybe we'll be giving prep regimens and transplants in the home one day, but not now. I think that patients aren't eligible because of their fitness or their age. There really is, that was not a condition for our patients to enroll. So the patients on this trial, we had a handful, 7 of them, who had a Karnofsky performance status of 70%. So this isn't, they don't have to be the top notch to do this. And many times it's much easier for them to not have to come into the clinic. So I think, again, the type of transplant doesn't matter. I think everybody could be eligible. It's just you have to have the right infrastructure. So the two things I think are just the eligibility, and that, we don't do the preparative regimen or the transplant in the home. It's just the post-transplant care.
Okay. And then what's something about HBT that's not often talked about, but you wish more people knew about?
Talk about the challenges. Don't acknowledge them and don't listen to the staff about the challenges. You're not going to be successful. I think the other thing is to think about those caregivers and how can we provide support to them when they're not coming into our space. So I think those are some of the things that we could do a better job of. Also using our ancillary support. So I'm the clinical nurse specialist for the program. So if a patient has questions about something specific that's in my area of expertise, that I could do a video call with them. If they have questions about diet, have a registered dietitian reach out to them. And we do have the ability to do that. I don't think we do that enough. I think we could probably be a little more proactive in getting those services to the patient while they're in the home as well. So just some kind of tidbits that I think we've learned along the way.
Those are good things to know and to think about, as you're going through, whether you're setting it up or you're already starting a program, just to think about those things. And then Lastly, what are some resources, both for the patients and providers who want to learn more about this treatment option?
I think to reach out to the centers that have done it. We've actually had several centers come to visit us or to talk with us about how we implemented this. And our medical director, Mitch Horwitz, and our division chief, Nelson Chow, are very open to having those conversations about what resources are necessary. So, and I'm glad to chat with anyone, or Krista, our coordinator, is glad to, and Jennifer Frith, who's our operations director, is glad to share any of our experience with it. And again, looking through the publications, and again, most of it's come out of the Karolinska at Sweden, in Sweden, look up those publications to see how they, as the real experts and pioneers of this, have been so successful.
Great. Well, Martha, like I said, I could talk to you about this for a long time, but do you have any final comments for us today?
I don't. This has been awesome. Thank you so much for inviting me and for allowing us to share our work that we've done here, and just a great opportunity. So I appreciate it.
No, thank you. I've enjoyed it as well. And I think that it's just really great to get the information out to the ONS members and to any of our listeners who join us and want to know more about this and just the work that you guys are doing. Great job. So thanks.
Thank you, Stephanie. I appreciate it.
Earn a reputation of excellence in cancer care. Visit facs.org/cancer to learn how to achieve accreditation from the American College of Surgeons Cancer Programs. And be sure to visit the Cancer Program's virtual exhibit booth during the 46th Annual ONS Congress. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.